Yeah, well, thank you all for being here. These are the true cards right here, because as I was saying before, this is after lunch and before the after party, and so I mean to come to the session, the diehards right here. And so what I want to talk about today, medical devices in a connected environment, and a little bit about the journey that Providence has been going through in this space. A little bit about me. I've been with Providence now 27 years in a number of different roles, 38 years in the HTM career field. Held a number of different professional roles and supported our biomedical association up in Washington State, working with our colleges and other professionals up there just to get the word out about HTM as a career. As I go through this, if I do mention any vendors, products, equipment, or whatever, just there's no conflict of interest. I'm just presenting data. I don't work for or get kickbacks from any of them. So to make sure we're all in the right presentation, including myself, medical device and imaging modality procurement has become increasingly more complex as these devices and systems are deployed in a connected environment. And in deploying them, ensuring that the clinical, technical, and service priorities are achieved through the selection and deployment process is equally as complex. And so I want to walk through what that looks like and use some examples from our organization to really talk about how do we do this now? Where do we need to partner differently within our organization and outside our organization? And where there might be some potential barriers as we go forward. Gonna introduce a little bit of Providence here as we go through this, talk about how we organized ourselves and our approach towards this within our organization, and then where we're going next through these various topics. So who is Providence? So Providence is a healthcare system now consisting of 51 hospitals, 1,000+ clinics across 7 states. And we are a combination of healthcare organizations. Not all of them started as Providence organizations, but we have, over the years, my 27 years within Providence, we've gone from 14 to 17 to 30 some to now 51. We also have a high school and a college. We have 18 supportive housing facilities and a credit union. So just an odd thing there. And then we also have our Hyderabad, India, Providence Global Center. And we utilize the Providence Global Center as a location where we're doing a lot of IT, technology, cybersecurity, contracting, reviews, those things. They also help support us through help desk, our cybersecurity operations center, those things, so they can kind of follow the sun. And so we have better 24-hour coverage around our network and various things within the organization. So as we've come together as an organization, one of the things we've also been involved in is bringing together our 18 different clinical engineering teams into one enterprise program. And that has been quite a journey that we completed in a year and a half ago. I think we finished bringing together a single organization under clinical engineering. In that process, we also got moved into IS. And so our clinical engineering team is in the same division as our IS field services, our help desk, and some of our cybersecurity program. All under that banner, we call it Clinical Technology Services, but we have unique leadership for the clinical engineering space and for the IT space under that division. Also, during all of this, as you heard from Travis, we standardize on the Nuvolo platform. And so we combined our 14 different CMMS platforms into a single platform, which is Nuvolo, which then brought us to really understanding more of the technology implications that we have to manage in this connected environment. So across the organization, 120 some thousand employees, we have over 700,000 connected devices. Our clinical engineering teams support about 400,000 devices, and 60,000-ish, and it's growing all the time, are network connected. But when you bring all of this together, multiple systems, multiple infrastructures, multiple platforms and applications and medical devices, it really starts providing really an insight into how much more complex it is to purchase medical devices. Not everything is the same. The infrastructures aren't the same. And so we've been on this journey not only from an IS perspective to bring standardization to our infrastructure and eliminate vendor managed networks and move them all to our own company owned networks. But with all of this coming together, a wide variety of technology, a wide variety of platforms, and all the differences that we're learning about in the technology life cycles. And so if you've been attending this kind of theme within the MD Expo, you've seen yesterday talking about contract management and how you do that with assets. There was Carol did 2 sessions today, one around inventory and then earlier around setting a matrix to replace end of life and end of support stuff. I'm hoping that this kind of brings some of those thoughts together, but we look at it from a little bit different perspective when we're moving to procurement. So our problem. We have disassociated and siloed processes for procuring equipment, and locally, those teams, they manage the budgets, they could buy what they wanted to buy. It doesn't drive us or move us towards standardization, which then creates more variance. It creates problems with integration. There's more security challenges, and ultimately it costs us more money. So why is that a problem? Well, I'm sure, like the organizations you're a part of, we're struggling with our bottom line as well. There's limited capital dollars. We have significant technical debt and cyber vulnerabilities in our medical device space. Carol earlier was talking about an example. WannaCry came out. I remember when I got the note that told me that I had 2 weeks to identify and remediate or replace all of our devices that were still running Windows XP. And like, well, there's 0 chance of that happening in 2 weeks. There's probably 0 chance of that happening in 2 years. But we have that in our environment. Misaligned priorities across the enterprise, and this is a big one, because across the enterprise, all of the different priorities that land within the IT department around infrastructure, server management, architecture, all of those pieces all impact this space. And they may be focusing on a space that we're not ready to engage yet with medical devices or connect to. This is a barrier to innovation. This is one of the words you continue to hear. How do we innovate in the space? How do we do it? We want to make sure that when we're collecting data on our patients, we can use that data to help their care, right? Versus just have monitoring. And then all of these variances, it's a resource drain. It's financial drain, it's team drain, it's all the meetings, it's all the discovery. We needed to be better. So we set some goals. As a high level, as we're looking at this, we realized we needed to create a more end-to-end process for medical device selection. And this includes the procurement and implementation process, where we need approvals, where we need to make sure that we have the right reviews, cyber infrastructure, all of these different things need to be done ahead of time. We want to make sure that this becomes easier for our caregivers, and we can do it at the business. And sometimes it's like trying to turn the Titanic. It takes forever. But what does this resolve? Number one, with limited dollars, we can have an informed capital life cycle process. Super important. Number two, we can start aligning standards, not just with medical equipment, but making sure that we're aligned with the clinical standards and what they're trying to do and what is their future state or North Star, and our security and infrastructure. Make sure all of those are aligned. This next one, this purpose versus preference, and I'm going to mention this again later on, but we had to get out of this idea of, hey, I know this vendor, I've worked with this vendor forever, so this is the one that I want, and move away from that preference-driven process to purpose-driven. If we want to innovate, if we want to move towards our future state, we have to be intentional with what we're purchasing. Needing to move at the speed of business and then continue to see where this drives us toward innovation. I know that our clinical informatics and our nursing folks have ideas around innovation. How do we partner with them to make that happen through the procurement of the right medical devices? So our approach, we identified the problem, we have some goals we want to achieve, so how are we going to get there? First of all, it's this idea of socializing with identified key stakeholders. Let's look at this end to end. That way they understand what we need to get done and we can work together through it. Make sure that the clinical care and technology standards are aligned end to end. A minor challenge. Establish standards with key modalities and equipment. This is one of those spaces where you could easily boil the ocean, right? It's like, well, we need to start standardizing all of our medical devices. Well, do we really need to standardize all of the medical devices, or are there key modalities or technologies that we need to do that with? And simplify the process. If we're establishing standards, how would our clinicians and folks that are submitting know what those standards are when they need to buy something? When you think about how long medical devices are in our environment, and you think about those service lines or business owners within your hospital and the nurse managers, how many of them are there longer than the life cycle of the equipment? So if they come into our organization, how would they know what the process is to know what a standard is, and how would they procure it? We need to make it more simple. Develop status and feedback loops. How many have ever submitted tickets and it goes into oblivion and vapor? I don't know what the status of it is. This is something we found in our process, is that if they did submit to procurement something and it didn't meet a standard, it went into a black hole. And then they never got feedback on, well, why? I think it's coming. I don't know if it's coming. What happened to my requisition? Make sure it's consistent and repeatable, and then develop capital lifecycle and technology roadmaps. I think one of the things that we learned in this is it feels like often building a process that can be repeatable, and we want to build roadmaps. But if we don't do those two things in context of our future state, then this is just work that we're going to have to redo when we establish what our future state is. So there needs to be an order to this. So here's our journey. Here's the nurse manager. She needs to buy something for monitoring, and she envisions clear out on the other end, this is what it's going to be. What she doesn't know, and probably doesn't need to know, is that all of the other inputs that need to happen to get there. The documentation requirements, the clinical act, all the technologies and connected pieces that need to happen, EHR verification and documentation and all those things, and then all the service implications and finances. There's a long road between her thought of going, oh, this should be easy, and ultimately what it looks like when it's deployed. And I've got some other examples for this. And so this becomes the challenge, is that everybody's doing what they should be doing within their silos. Finance has their lane and their silo, and sourcing and contracting has their lane, and clinical engineering is doing their stuff, and information services, they have all of their pieces. But coalescing this and having this team integrate and connect can make this much easier and establishes process much easier. But how would the submitter know? right? She just wants to replace some monitoring. This is that space where it moves from being this transactional, and I have some thoughts on this on another slide, but this is a very transactional approach. I need to replace monitoring, and that's what I want to get. All of the new stuff in between there is we want to use those tools to be transformational forward. And if you have thoughts or questions, I mean, feel free to just raise your hand or shout out. So organizational goals. So now we set what we wanted to do with the procurement process, but we needed to start getting aligned with our clinical leaders, our technology leaders, our organizational enterprise goals. And I just tried to simplify them here. Is that, on the clinical technology and data side, we needed to stabilize what we have, what we can't replace, modernize. I mean, there's areas where we have legacy technologies that, okay, if we can't replace, there still is a level of modernization, stabilization we can do, but we need to be driving to an outcome. Innovate. This is a space we continue to, again, I hear it over and over again. We need to find innovation. A lot of this is in data management and those spaces, but it's working its way toward the bedside. And then simplify. If we can get some of these clinical technology and data decisions aligned, standardized, and we can then find ways to extend our funding. We can make decisions that actually become force multipliers. You make the decision one time and you can scale it, right? You don't have to make that decision over and over and over again. And we can work with greater speed with the goal of working towards, right, better workflows, better data outcomes, better patient outcomes, and more insights. Not just transactional, but transformational. Being very purposeful with the purchases, making sure we go through these steps as we're looking to procure. Yes.
Transformational to automation.
Yes, that's a big one, and automation, I would put it in this sense from a nursing workflow and all of her technology tasks. What is it that we can do with technology that will move her away from a keyboard and allow her to, work at the top of her nursing license? Mm-hmm. Yeah, and that continues to be a conversation too, is that wherever we see clicks or needing to write something down or to chart something, is that a data point that could be automated versus interacted with?
In 5 years
Oh
or 10 years?
man, that's a great question. Right now we're focused on technology goals through 2030, so over the next 5. Yeah. The AI piece is, I think, where our digital teams are trying to accelerate that, and they have longer range goals than that. But from a medical device, we're looking at about 5 years.
And who is the owner of the data at the end of the wheel? So, for example, in this case, that Providence or someone else?
Providence. Yeah. Yep. So I had a very simple diagram before where the nurse wanted to order a monitor. So one of the pieces that we've done to try to help explain and visualize all the connectedness in our environment is simply put it into pictures. and it's amazing what this has done for some of our conversations to really understand how complex some of these spaces are. And you can see how, if in this clinical space, we've established standard devices and a standard support model for this, that's great. That's transactional. But we need to connect into our infrastructure and our data sources. And in this specific space, when you start getting into these servers, host servers, communication servers, web servers, integration engines, all of those pieces, within Providence, we have IT teams for that. So we don't buy physical boxes very much anymore. If we have to, we're virtualizing them locally, or we're virtualizing them in a cloud, depending on what that device or application is. But if we don't know what those things are, if we're making the clinical and medical device decisions out here without taking that into consideration, we're in trouble, right? We're going to miss something. We need to understand, what is it we're going to do with the data? And we were talking about, how do we want to use the data we're collecting from here? And what are the other sources that, as we move forward, is the data going to be out there in our EHR from other sources that we would connect to a patient? So let's talk about wearable technologies, hospital at home. If I were to go, if I needed a procedure done, and I go for my preoperative procedure and they put a wearable on me and I go home, they're monitoring my temperature, heart rate, all those kinds of things, and that data is going somewhere. But how do we make sure that if that data is available through a clinical application or a cloud-based application, how do we interconnect it to, I get it when I arrive and they put me on a monitor, and then they put me under anesthesia and I recover and I'm down in ICU or wherever I go, all of that can be connected, and it's helping drive patient care. Then I can wear the wearable home after I get out, and they can monitor me for a few more days before I can take it off and get a clean bill of health, and I'm off and rolling. But those are the things that, if you're not looking at this end to end, we miss the opportunity for that innovation or that ability to transform how we're using the data. So this is just the technical side, right? So we're saying, hey, look, we're monitoring, we're capturing data, we have EHR data probably coming back into a workstation here. All of this is happening in a very symbiotic way. It's sharing data. That's awesome. It's safe, it's scalable, it's secure. We're doing all the right things. Great. We're using Azure. Yeah. Yep. So this is all great from a technical perspective, but we should probably stop and talk with our clinical leaders and say, what else beyond just having the monitors here are you trying to accomplish? And this became a very interesting conversation in our organization, because as we talked to our leaders in this space, they didn't just want a standard for monitoring, they wanted a standard for each care area, so that our ICUs, where they're providing similar care, look like similar ICUs, and our ERs are configured similarly within the organization. So in all of these different spaces, that we have a telemetry strategy, so that wherever we're using telemetry, it's consistent, we can deploy in a consistent way. They want to increase automation to reduce, this is what I was talking about with the admin burden for nurses. We don't want them on their mouse and keyboard. How can we use this data and move this data differently without their intervention where we don't need it? Better visualization for the clinical action. And this might be part of the ability to get information from the systems back to the nurse on a mobile device or a handheld device. How this is configured within the architecture matters. And we actually had this example where we were deploying systems. We use Azure Cloud, we use virtual, and then the stuff that's locally in a rack mount, locally in an IDF closet or something like that. And we found that the connections between these spots met the vendor was under their standard time, which is going great. It's got to be this many milliseconds. It can't be more than this amount of time. But when you connected the chain, it broke it. And by breaking it, that also meant that all of this then shut off from all of that. This is operating in local mode. The nurses are now in downtime procedures to manually chart. If they were connected to a mobile device that provided them an alert or alarm, that's disconnected, right? I mean, so there are impacts to this, and We felt it in a real way. In this particular case, yeah, the timing and the transfers and all of that, there was, yeah, we were under the time frame until you put the whole chain together. But this is part of their goal. The clinical goal was, how do we make this a place of healing? We want it to be quiet. We don't want all the noise going off and all the phones and all the alarms and all of those things. How do we do that and configure this system so that we can push things to a mobile device, not lose the local alarms? You never lose the local alarms at the central and those things, but how do we do that? We couldn't do this from before if it was just a transactional purchase. We needed to look at it from end to end.
Before you go,
Yeah.
this is very helpful. I've seen this in action too. I felt these pains too. But to achieve that standardization in your first bullet there, it seems that there needs to be a consistency of the clinical protocols and standards of care. How did, before you can design all this technology, that has to be in place.
Yes.
Every tele unit, every ED, every ICU does not behave the same way, nor do they have the same patient types.
Correct.
So how did Providence tackle that piece so that you could overlay this technology?
What we've done this in physiological monitoring, CT, MR, mammography, cath labs, anesthesia, ventilators, just some places where we've done standardization, contracting, and those things. What we establish is what we call a base configuration or a standard configuration.
No, not the devices. I'm talking
No,
about
and that's
okay.
Yeah.
Okay.
And so what we did was, by creating it in this particular space, we would say in an ICU with our nursing leaders, said, what would be your, based on the care you would provide, what would be the we haven't got to the alarm part yet on the configuration, but that's coming. But they established what their configuration was for the devices that would be there. If they have other specialty in that space, then they can scale up. But we wanted to make sure that there was whether the same size monitor, same size configuration, the same amount of modules, whatever they would need. If they have something special, they can scale up and add that to the standard configuration. If they're doing something different in an ER or in an ICU here in a smaller facility that they're not doing, in a large facility that they're not doing in a small facility, the smaller facility probably doesn't need that level of technology in the room. But we're using base or standard configurations, and then they can scale up to their specialty.
Another question from the phones, if I'm wrong, just make me right. So when we are talking about the centralized system, somehow when we just ended up to the cloud, it means we decentralize the system. Means Providence making their own data and information, and somehow we just decentralize, however it's centralized. So how you explain this gap between these 2 points? Because everywhere we say centralized, but somehow all of these action ended up to decentralize, and we can just get into the innovation and all of those steps ahead. To me, this look like that. I mean, not just Providence, all other companies somehow decentralizing the data and information, but somehow, because we start from the centralized point, we should just figure it out. I was wondering if you have some opinion.
Oh man, well, I would say as we move the data, I mean, our EHR is going to be that source of centralized data, right? So our Epic platform is going to be that one centralized space.
The point that
Man, from a data perspective, the goal has been, centralize it there, source of truth, and then utilize other tools over that data to, I mean, to, for AI, for algorithms, for early warning scores. I mean, for all of those kinds of things. But I think it's not my area, but I think that's where they're doing all of that in a centralized location. This is a tough one though. It's one thing to centralize across ministries or geographies with data, but doing it with technology is a different beast.
So this is there, but here is freedom somehow.
Yeah.
When you go to the data, it means, okay, from that point forward, you can do a lot. So
You can't go back and redo it, right? It's just,
unless you never put that flashback.
yeah. Okay. So here's another challenge. So you saw the technology maps and all the pillars of data and information and all the different technologies. One of the other things is that the OS and software life cycles now in capital equipment. And it is one thing to manage equipment over its life cycle. And this is a busy slide, and so I'll just walk through it a little bit, is that when we buy something, we typically get a sense of what the manufacturer would call the useful life. And a CT vendor might say, 9 years or 12 years or whatever that is. I built out a 15-year cycle here. So that's so a 15-year equipment cycle, the manufacturer says we're good for 10. And then the manufacturer may send us notification that, hey, we're no longer building them and we're going to end of life. That's about year 13. And then year 15, it's end of support. I wish that wherever we had this data within our system, we could purchase at this speed. We can't, and we haven't invested, in order to do that. So we have built up significant technical debt in our organization. So within Providence, it says 10, we say 12. Our typical use is 15, and time that they're saying it's into support. And so we're out there at year 17, still trying to go, how are we going to manage this device in our environment? And we're past end of support. Now, with legacy equipment, that's how we managed it. But now adding OS life cycle and software life cycles, this kind of changes the game. And we have to be more aware of, 5 to 6 years out, doing an OS lift or upgrade. There's making sure that we're getting patching into our processes so we can secure the environment. But these costs associated with making sure we're keeping it enough so it can integrate into our systems is a big deal. When the other slide up with all the technology, I'm just going to go back to this, is that in each of these spaces and in each of these server stacks, there is a life cycle associated for OS, software, and all of those. And what we have discovered in a painful changes out on that end can absolutely impact clear back to the bedside. We had an example of, there was a security update pushed out to some devices in our organization a few months ago. It bricked a number of devices, and our ability to recover those meant we needed to replace them. And later, items bricked the activity clear out on this end. But we also know that if we're making changes here, we better make sure the teams upstream are aware of what we're making, because we can actually cause issues going the other direction. Whoops, wrong way. So capturing this information into our CMMS is really important to move forward because it becomes another cost we need to manage and finances are already constrained. Let's see. Yeah, and then the other costs associated with this. I mean, we don't manage the operational software and updates. I mean, that's a clinical cost and a capital thing, but it does become extra dollars, especially when the vendor incorporates their OS patches and their upgrades within their operational software at the same time. It all becomes capital expense. Go ahead.
What percentage of your fleet would you, or of your equipment would you say you have that? Meaning manufacturer useful life, manufacturer end of life, like, you know, and how do you capture that? And,
yeah, so we, for the manufacturer useful life, we did it based on our experience and some average age of devices that are in our system. So it is partially thumb in the wind plus experience that we did that with. And these dates really, you know, they're green and yellow. The yellow becomes the warning sign to go, hey, maybe we need to start thinking about this. The manufacturer end of support and formal end of life where we have those letters, we're updating that in our CMMS on an ongoing basis. So we get those dates. The other thing is that we actually put into our system some projected useful life from our view. So even though, you know, we buy it and the vendor says 10, if we know, we believe that we're going to be using it for 15 or 17, we have that as a field in there as well, just to give us boundaries to help us make decisions. In the earlier session, Carol had a map up there, and she had some green, yellow, and red to show about it. Yellow, 5, red. Having those kind of brackets gives us that window. It allows us to take into factors locally around, you know, then how much is it getting used? If we're going to replace it, you know, is this part of our clinical strategy locally that we want to replace it, or is that service going away? We can start having those, but it facilitates the conversation.
Just a follow up on that is depreciable. You know, your lifetime depreciation or your depreciable life of the asset. American Hospital Association puts out a guideline. Mm-hmm. Is that something that you add to your CMS, or is finance on your?
We actually had a lot of debate about if we put that information into the CMMS because it's so short compared to, but the point that you brought up and that you're bringing up is, but that is a point that's visible in industry. So we including it in some of our reporting, but we didn't put it into our CMMS. At this point, but that is a recognized date. And so it's not just us saying, hey, you need to replace it. Here's actually a data point.
Well, I think it's also a showstopper, meaning you still have depreciable life. You're not replacing that unless you have a real good reason, right? So that's a plug to keep people on all the equipment that your debt, that's your equipment debt still out there.
No, that's a good point. That's a good point. So yeah,
Your Providence useful life, is that based on your maintenance data, or where's that number?
It's age it's age and service and maintenance data.
So you're using some of your maintenance data. Okay, cool.
So as we're going forward and we're looking at this end-to-end process, just going to talk about some of our discovery and actions and maybe some lessons learned. One of the first things we've talked about is it's just lack of awareness of a procurement process and the reviews that are necessary across the org. Not a lot of surprise. People are still doing good work. They just don't know that on the other side of the wall is the person you got to hand the next data to. Yeah. limited understanding of medical devices connections within IT teams. This has been quite a level of work. I heard in one of the earlier sessions, it's a point of contention or tension within teams. Medical devices are not IT devices. They have a very need to be respectful of that and aware of it. And with all of the different pillars, would be a problem about, that's not my space, right? So now this is when things go into the black hole, is we don't know why it was stopped in security, but it's not their, what's their next step, right? And so we had to get better at communicating. And so we've been building partnerships across our organization with key spaces. We need to make sure we're creating visibility to the needs and the impacts. We have ministries that maybe want to buy equipment, but because of the infrastructure in that unique hospital, they're not ready to take the new equipment. And so making sure we get that visibility, make sure we're constantly reviewing the processes. And again, we're keeping innovation in there, because if there's an opportunity to do something different, and it changes how we do work or collect data, how do we do that? Yeah, go ahead.
You treat capital and non-capital process differently. Looking at your end-to-end.
So give me a non-capital example.
Somebody just wants to order another scale.
Is it connected or not connected? Oh, it's yeah, that is one of the flags right now. Is there intent to connect? Do we have a standard? All those kinds of things. Yes. Yep. Yes. Yep. Common language is critical to success. I got to tell you, I mean, I've done a lot of work in this space. One of the things I was asking in an earlier session around CMMS platform is they continue to use the term clinical technology. And I said, why do you continue to use clinical technology when you're talking about medical devices? He's going, well, that's just the name of our module, right? Well, locally, clinical technology could be the nursing workstation, could be the patient monitor. If those two things are the same, workstation monitor, patient monitor, and she has a problem and says, my monitor's broke, right? And we have a problem with language. And so even in the procurement space, understanding the difference between integrated, interfaced, connected devices, adjacent devices. I mean, all of these different things matter as we move forward, and making sure we understand those. Make the work visible, and I said, and include pictures. Pictures sometimes can tell a completely different story when you see it. And instead of the not my job, how can I help, right? This isn't my space, but I know whose it is. Let's do that. And it gets to be a challenge, because in our organization, maybe like in some of yours, how many times have you reorged in certain spaces, and that person you used to go to is no longer that person, right? Because they're now in a different division. And it is strange how you can have such a large organization, but some of these decisions come down to one person, or there's one person that can move it forward. And timing, being aware of planning and budget cycles. Our construction cycles, our IT cycles, our capital budget cycles, they may not be all aligned, but understanding how we get into that process so we can make sure we can not only get in the planning cycle, but then be aligned with the other technologies and their priorities. This is internally. One of the other pieces that we've had to engage differently is with our vendors. To move beyond transactional to transformation, it's sell us 10 more at a discount price. We need to make sure that as we're moving forward, they understand what our strategy is, so that if there's things that they're doing or things they're planning to do, it can actually help us move in our transformation and move that forward. We actually created a vendor management council, and this council includes procurement, clinical engineering, some of our strategy folks, clinical informatics, our clinical applications team, and they all come together, or we all come together, so that when we have these meetings with vendors, it's one versus going to each of the different ministries or having these individual conversations. Why does as we've consolidated and got to one voice and said, look, this is our strategy. Now, how are you helping us? They can't go to anybody else in the organization to talk a different strategy because we've established it with them. We also created a scorecard for the vendors that would, that goes through things like service, contracting, their contact points in the organization, innovation conversations, all of those things. And we've had conversations to go, hey, look, in this area, why is it your people are having these conversations when this is the location? And because you can't meet our goals with us, then we can use other vendors. And so we're trying to strengthen those partnerships. And this goes into the, some of the challenges as we're with vendors. They want to know, hey, it's as hard for us as a vendor figuring out what you want to do, and we're talking to 51 hospitals. Who can we talk to that can also help us understand? And so getting the right stakeholders together, we're measuring the vendors. We're doing more understanding our technology alignment with where they're going and their directions. Where we really get into trouble in this, if you work with vendors very often, they're trying to sell you something. Sometimes you've got to be very specific about setting the boundaries for the conversation. It's like, look, we have some strategies, but what we're not trying to solve is every technology issue we have across 51 hospitals at one time, right? So let's have a more specific conversation versus that. And then so we've learned a number of things as we've moved this forward. Defining the North Stars are super important. Being intentional about those things so we maintain our goals end to end. So where do we go next? We're continuing just to build and refine this process. It's amazing that through this, having a tool or a platform to be able to just go, hey, is there something we can just start dropping this information into, and it routes it to the right people, and we get the right approvals, and then it comes back and we get it all and we send it to the vendors and they send it back, and it's all timely and happens in a week. And we've yet to find something that fits that. So we're trying to refine the process. So if there are tools, or if we need to build our own tool to do it, we can. We're also building the prioritization scorecard, and I mentioned that just a little bit. Building the heat map, because what our leaders don't know, they just don't know. And so we've brought all of our assets together in one database to be able now to look at priority assets and say, here's the heat map, right? We need $1 billion. We don't have $1 billion, so where do we start prioritizing? But getting that first view is really important. Making sure that when we are looking to procure, we're aligning it correctly across all of our strategies. Continuing to work on building our technical standards and our medical device standards so that it's visible to everybody. And if they're looking to procure, they understand the process and what needs to actually happen to complete the work, and then continue to build the right partnerships internally. So, in space, there's, like I said, with our medical devices, 100,000 of them, we've got significant technical debt, way out of it, in a year. So how do we become more intentional, more to meet all of those goals? So it is a challenge. There's a lot of different inputs, but we are feel like we're making headway. We've standardized in a number of spaces, and looking forward to just continue to do the good work for Providence. So. Awesome. Thoughts or questions before, go ahead.